Hi, welcome to today's ICD-10 coding and billing discussion provided by North American Management with the great participation and assistance of our friends at SS&G Healthcare. I should note this is not geared toward hospitals. Maybe at some other point we will, but this is really more focused on practices, whether private or public or federally qualified health centers. I also want to note that this is being done separately from the National Center for Health and Public Housing, but I also want to note that the National Center will be providing workshops on ICD-10 at national and regional conferences this year, as well as developing a tutorial on the subject. So that is all available. This is just a general overview on the subject of ICD-10, which should be beneficial, to all to some degree. And then if people are interested in additional services, that's possible, but that again is outside and beyond the cooperative agreement. Some of those services can be in-depth and customized training, on-site coaching and assistance and all that kind of stuff. But the purpose of today's session really is to just get into ICD-10. So with us today, I have Earlene Franks and Toby Klein, who have great experience and expertise in this area, and I'm going to let you let them walk you through this thing. SS&G, of course, has been in the business of coding and billing and accounting and working with practices, including XQHCs, for a long time. And that's why we're happy to have them available today to help all of us with what's, I guess, one of our most important functions, and that is to ensure revenue cycle management to ensure that we can do the work we want to do for our respective patients. So, Earlene, why don't you take it away?
Okay, good afternoon, everyone. First, I'd like to introduce myself. I'm Earlene Franks with SS&G. As Bob said, and I'm the Associate Director here, and I oversee the coding and the auditing department. And we focus on performing chart audits and chart reviews and assisting the physicians with the proper documentation and education in order to help them, receive the highest reimbursement possible for practices. My background is I'm a member of AHIMA, and I sat on the board in Chicago to help develop the CCSP exam, which is Certified Coding Specialist on the physician side. And also I am a trainer through AHIMA, not a certified trainer. There is no certification for a trainer, but I'm considered an approved trainer through AHIMA. So, and as Bob said, that today's ICD-10 overview is going to be on the physician side. And for those of you, the ICD-10-CM is for the clinical modification. That's what the CM means. And then there's also the hospital side, which is the procedure coding system, the ICD-10 PCS. But our focus here is going to be strictly physician side. So with that, I'm going to let Toby introduce herself because she'll be speaking a little bit later and give you a little bit of background of, what she's done and her certification.
Hi, my name is Toby Klein, and I'm a senior associate here at SS&G Healthcare, and I've been in the healthcare field for about 17 years now, coming from private practice, and then I've also worked about 5 years in a large radiology billing company where I audited radiology services. And now I do mostly E&M coding and auditing, and I've also had my education in ICD-10 for physicians. I am a CPC, certified professional coder, and I also have my RCC, which is a radiology certified coder. I'm a member of the AAPC, the American Academy of Professional Coders, and I'm also a member of the American Institute of Healthcare Compliance, and that's where my training in ICD-10-CM came from. So that's a little bit about my background.
Okay, so with that, we're going to go to our first slide, the ICD-10, just to give you a few of the ICD-10-CM facts. As we know, the United States is the only nation that has not implemented ICD-10. It's set to begin October 1st of 2015, and there will be regular updates to it every year after that, starting in 2016. I'm not sure if anybody there has heard any rumors or had any emails come to them, but we're hearing that possibly ICD-10 may not take place until 2017, but as it stands right now, it's kind of rumors. It's out there from the American Medical Association. We get emails. They're trying to fight it. So you just, even though they say there might be another delay, just please keep moving forward on it. It's going to be the best practice for your practices and your physicians. As we know, there's been an increase in the chapters from 17 to 21, and the ICD-10-CM is based on the statistical classifications of diseases by the WHO organization, and the guidelines have been approved by the American Hospital Association, by AHIMA, CMS, and the NCHS. The transition of ICD-10 is happening because there is limited data with ICD-9 about medical conditions of patients and hospital inpatient procedures. As we know, ICD-10 is about 30 years old and it has some outdated terms and is inconsistent with current medical practices. And the structure of ICD-9 also limits the number of new codes that can be created. So many categories of ICD-9 are already full. The next comparison screen you've probably seen many times where it's comparing your ICD-9 to your ICD-10. ICD-9 is 3 to 5 characters, ICD-10 3 to 7. The first digit of the ICD-9 may be an alpha, the E or V codes, or numeric, and the digits are 2 to 5 numeric numbers. ICD-10, it could be, the digit 1 is going to alpha, digit 2 is numeric, and digits 3 through 7 can be alpha or numeric. And later on you're going to find out that some of the codes may have to have an additional placement, like an X. It's filling in that place in case they ask you for a 7th digit. So we'll talk a little bit later about that as well. There's limited space in ICD-9, as I said, where with ICD-10 there's a flexibility for adding some new codes. ICD-9 lacks detail, 10 is very specific. ICD-9 lacks the laterality, and ICD-10 includes it, which is part of that expansion. Who will be affected by ICD-10? ICD-10 will affect the diagnosis and the indecent procedure coding for everyone covered by HIPAA and the Accountability Act. It's not just for those who submit Medicare or Medicaid claims. The change, it doesn't affect CPT coding for outpatient procedures, and the changes will include providers, payers, your software vendors, your clearinghouse, and any of your third-party billing services. And what should we do? What should we do as providers to prepare for this? If you haven't already prepared, you first want to get together an ICD-10. And this is kind of what we have done here at SS&G in our coding and auditing department. We're creating that team, and we have a budget for implementation of costs for education, any seminars, any additional books that we might need, and we're also creating a timeline as to when, you know, we feel that these different phases should be completed to be prepared for this. And we want to identify your current and future educational needs for your staff. That could go from your front desk to your clinical to your office manager. So almost everybody in your office is going to have some kind of education for ICD-10. And you also want to communicate with your practice management system just to make sure that they're set up and ready to go for the new codes. What we suggest is you should communicate with your billing service and your clearinghouse to make sure you know, that you have the appropriate hardware and software. A lot of testing on 5010 has been done prior, so hopefully everybody is up and ready for that. You want to also communicate with your payers to see if there is any changes or anything that you might need to do as far as your contracts, because they will be affected. And you want to identify any changes in your practice workflow and any of your business processes for this. And what we suggest to start to prepare yourself is you want to purchase a copy of the ICD-10-CM code sets. Within your practice, you want to identify the top 50 codes that you currently use. Remove any of your unspecified codes. We're not real sure how the payers are going to pay on those unspecified codes. There are some that you may still have to use that, but it'll be a good idea to see, is that going to result in a denial? Is it going to result in a reduced payment? Those are unknowns that we don't know yet. So that would be part of your research and some education that you can prior just to see how you would be affected and how you could, you know, make those unspecified codes more specific. And you want to make sure that you review your documentation to make sure that it does support the ICD-10 code that you're using. And then just continue to educate yourself on the rest of your codes that you have, whether it's an additional 20 or 50. You just want to make sure that you know, you continue to do it. And what I had ran into a physician the other day, about 1.5 years ago, they got a software system, and he was showing me how the software system, actually he had clinical work set to his practice management system, and then he had a system called the IMO that he used, and he showed me how it worked. So what they have been doing for 1.5 years is taking the patient's diagnosis, you know, comparing it to the ICD-10 codes, and then going back and make sure that their documentation supports that. He's ready to go. He said it wasn't really as scary as what, you know, they made it out to be. So they're continuing to do that. So I would suggest if there's any way possible that you could do something like that, that would be great. And where can you find information regarding ICD-10? You can go, we've given you some different websites here. You can go to the Centers of Medicaid. AHIMA has a lot of good information on ICD-10. And, you know, SS&G, of course, us. We're here. We're happy to help you any way that we possibly can. All of our coders in the department here have had ICD training, except for a couple new ones that we have added to our department, and we will get those employees up to speed. And then every, you know, we're going to try every month, at least once a month, probably in the first of the year. We're going to go back to coding our cases and just, you know, doing some interaction between all of us coders here at SS&G to keep us fresh on the codes. You can also contact your specialty-specific society, and your software and system vendors probably will be able to help you with some ICD-10s. The GEMS, I'm sure everyone's heard about the GEMS, which is the mappings between the ICD-9 and the ICD-10, and they've been developed to do a transition between the two. The National Center for Health Statistics has released the GEMS, along with the documentation and a user's guide, which we have listed the website there for you as well. Now, we're going to a breakdown of the GEMS. There is an appropriate and an inappropriate use. So the appropriate usage of it is to convert multiple databases from ICD-9 to ICD-10. There is a variety of research applications involving data trends. The inappropriate use is there is not a one-to-one match from ICD-9 to ICD-10 for a number of reasons. And, of course, the one is the new concept in ICD-10 for more specific codes. And one single ICD-9 code may map to multiple ICD-10 codes. And then with that, I'm going to turn it over to Toby. She's going to go into a little bit more detail about the coding guidelines, some of the conventions, you know, that are very, very important, you know, when you're starting to learn about the ICD-10. Toby. Yeah, I'll do it. Okay. Good afternoon. So I'm going to finish up on the second half of our little webinar here. The coding guidelines. These are really a must for you.
Hey, Toby.
Yes.
Could I just bust in for 1 second?
Yeah,
a couple of people have asked some questions, and
okay.
There were a few questions that were submitted beforehand, and we'll get to those at the end. And then someone just asked a question about providing some examples of an example of an unspecified code.
Okay, you know, like an unspecified code in ICD-10 would be 401.9. You know, that's hypertension unspecified, where now, you know, hypertension benign is 401.1. So unspecified codes usually have a 9 at the end of them. Does that help as far as just kind of giving a quick unspecified code?
And I don't know, Toby, you can touch on the concept of an unspecified code. Just.
Well, okay. Does anybody? I don't know if anybody there has their ICD-10 codes or code books with them. That would be helpful if they did.
Somebody was looking for a specific ICD-10 code example that might be in in the ICD-10 list.
Okay, we have one here. Okay, take for instance. Okay, so does somebody have their book with them? Okay, for instance, we're gonna give you a code in ICD-9, which is 153.9, which says colon cancer. So when you go over to your ICD-10, you're gonna look up C18.9. And yes, I understand that also is saying unspecified, but if somebody has their book there and you look above there, there are several other ICD-10 codes that you're going to have. How many, Toby?
Say about 10, just 10. In that C18 category alone. So colon cancer, you know, everybody would, you know, go to the neoplasms and look up colon cancer, and it would be 153.9. But when you look it up in ICD-10, it goes from C18.0 all the way to C18.9. descending colons, splenic flexure, transverse colon, ascending colon. So now it's a little bit more, they're a lot more specific. But if the documentation just says patient presents today with colon cancer for follow-up, the only code you're going to be able to assign is C18.9, because that's all the information you're provided in that documentation. So what we're trying to do is, get the individual practices to understand that they need to help their physicians be more specific. So now the documentation would say, patient here today for discussion for surgery for their malignant neoplasm of the ascending colon, and then you would be able to code C18.2, because malignant neoplasm of ascending colon is C18.2. So it really does depend on what's on that paper, what's in that physician's documentation. We can't assume we know what they mean if they don't tell us on paper. So that's a good, that would be a good example of an unspecified code.
Does that help?
Yes, the response back is that was a helpful example.
Okay, perfect. Okay, good. And that's one reason why I was also saying, yeah, you could use the C18.9, but like I was saying, yeah, there's a code for unspecified, but how is that insurance carrier going to pay that? We have no idea. So, get as specific as you can. There are some unspecified in there, but please, if we don't have to use them, we don't want to use them.
So that's a good place to start on your, like on the list on your super bills. If any of the physicians put their diagnosis, at the bottom of their super bill, you could go through that super bill and actually show the physician the expanded codes for just some of their more general diagnosis on their super bill, which will help them, as far as documentation goes, clinical documentation. Okay, so if we'll go ahead and we'll kind of move on to the slides again. So if anybody does happen to have their book, have an ICD-10 book, if not, you can kind of just make your little notes on the paper. Hopefully you printed it out just to make some notes. It helps. The section 1 in the very front of the book is on page 3 of the coding guidelines, so it's at the very beginning. Section 1 says conventions, general coding guidelines, and chapter-specific guidelines. That's where a lot of what I'm going to talk about is going to come from. The coding guidelines, other than in the front of the book, you could Google, if you would just go to the Google line, on your computer, you could type in ICD-10 CM official guidelines for coding and reporting, and it'll say FY fiscal year 2015. You just put that in your Google search line. It's going to come up to the CMS guidelines. You'll probably have a couple of them there you can look through. There's about a little over 113 pages. It's the same as the guidelines in the front of the book, but what's kind of a nice handy tool is you can save those guidelines to your desktop, and they're in a little bit larger form, a little bit easier to read, and I have actually a copy that I printed out, and that's where I keep all my notes when I'm referring to my guidelines when I'm coding, like for some of the more complicated things like HIV and sepsis, chronic conditions, acute on chronic. So it's just a nice little, it's a nice tool that doesn't cost anything for the offices to be able to utilize. So they really are a must to understand. And remember, the same guidelines are in the front of the ICD-9 book. A lot of us, our fear of ICD-10, I think, comes from the fact that we really didn't have a lot of education. I didn't. I just sort of kind of was presented with a diagnosis code, and the practice manager said, hey, here's how you look it up in the book, and I just kind of found my way through there. So I was never really didn't have a lot of official education on ICD-9 guidelines. So they do seem a little scary until you realize they're in the front of the ICD-9 book, too. So they really don't take precedent over what is in the book itself, but they're a really good, helpful tool. So the tabular list, it must be referenced to finish any of the codes and guide you with additional directives for appropriate code assignment and sequencing. So really, when you look them up, when you look the code up in the alphabetic index, and then you follow the guide, and then you go to the tabular index, all of those little notes that are in the alphabetic index and in the tabular index, really, if you pay attention and get used to reading them, they pretty much help direct you to the correct code. And then you can reference your guidelines when it comes to things like if the patient was admitted, the guidelines of what the patient presents for the encounter. So they do work hand in hand with each other. The alphabetic index consists of the following. Same pretty much as ICD-9, the diseases of index of disease and injury, the index of external causes, the table of neoplasms, table of drugs and chemicals. There is no hypertension table in the ICD-10 book, as they are now incorporated into the code themselves. The tabular list, it contains categories, subcategories, and codes, just as it does in ICD-9. So as I'm talking, this is still all in the front of the book. It gives little examples of what some of the newer things in ICD-10 are, and one of them is the X placeholder. So the placeholder character, it utilizes the character X, and it is used as a placeholder at certain codes to allow for future expansion, as Erlene was saying earlier. The code at this time may not expand all the way out to 7 digits, but and we'll talk about that in a few minutes. The X may be needed to actually plug in the places in between to make sure that you have a diagnosis that has 7 characters when it is called for. Certain categories have applicable 7th characters. The applicable 7th character is required for all codes within that category, or as the notes in the tabular list instruct. So all you got to do is look at the notes, and when you find the code you're looking for, when you find that subset of them, follow the directions. The 7th character must always be the 7th character in the data field. If a code that requires the 7th character, of course, is not 6 characters, then a placeholder must be used to fill those empty spaces. So now we're going to talk about extensions, and that is pretty much the reason for the whole placeholder character X. The extensions are listed here, and these are just 3 of them. There's about a total of 16 extensions total, but we're going to talk about these 3. A is for initial encounter. It should be used while the patient is receiving active treatment for the condition. You're going to find this a lot in the musculoskeletal portion section of ICD-10, which, by the way, is the largest section in ICD-10. The extension D is for subsequent encounter. For encounters after the patient has received active treatment and is now receiving routine care for the condition during the healing or recovery phase. The extension S is for sequela. It is used for complications or conditions which arise as a direct result of the condition. such as a scar formation after a burn. You use the injury code and the code for sequela. The S is added to the injury code, not the sequela code. The sequela code will be found in the alphabetic index under S for sequela. So that's a good that's a good area right there to get familiar with what the sequela codes actually are. You're going to find sequela codes such as polio, tuberculosis, fracture. A lot of those types of codes are going to be found under S in the alphabetic index under sequela. So there, of course, that is sequela replaces the late effect, which is no longer in ICD-10. That's where you look now in the ICD-9 book under late effects. So, so what you're going to see before we move on real quick to the abbreviations is you're going to see in the musculoskeletal section, you're going to find, you're going to look up, say, fracture of the wrist. And then you're going to move into fracture of the upper end of the ulna. That is a 4-digit code when you look at the category, and then it is broken down into subcategories for unspecified fracture of upper end of right ulna, and then there's a code for unspecified fracture of upper end of left ulna, and another code for unspecified fracture of upper end unspecified area of ulna. So right away you can kind of get a feeling of where a lot of those new codes are coming from in the musculoskeletal section. They're now broken down into left and right. Some are bilateral, and some then are unspecified. So that section of the diagnosis codes grew quite rapidly under ICD-10. So the most common extensions, where am I? That's the wrong one. Sorry. Okay, moving on to abbreviations. Not elsewhere classifiable. This abbreviation is in the alphabetic index, and it represents other specified. NOS is not otherwise specified. So we have not elsewhere classifiable, NEC, and then not otherwise specified. This abbreviation is the equivalent of unspecified. So when you're looking up your codes and you're transitioning from your unspecified codes that you're used to using in ICD-9 to ICD-10, when you come across the NOS, not otherwise specified, those are the ones that you want to go back to your physician and give them the more specified codes under that subsection now, because that's usually going to be found at the very last code. There's punctuation, same as in ICD-9. Brackets are used in the tabular list to enclose synonyms, alternative wording, or explanatory phrases. Brackets are used in the alpha index to identify a manifestation code. So that's a good thing to keep in mind. Parentheses are used in both the alphabetic index and the tabular to enclose supplementary words that may be present or absent in the statement of a disease or procedure without affecting the code number to which it is assigned. The terms within the parentheses are referred to as non-essential modifiers. They're just helpful guides. Colons are used in the tabular list after an incomplete term, which needs one or more of the modifiers following the colon to make it assignable to a given category and complete the code. A dash at the end of the alphabetic index entry indicates that additional characters are required. So when you go to the alphabetic index and you look up a code and you write, you've got your finger and you're running your finger down the codes, where the code in the alpha index has a dash after it, you're going to know right away that you're going to have more characters that you need to find. Also, while you're in the alphabetic index, for those of you who have an ICD-10 book to look at, there are very faint gray lines. There are two of them in the alphabetic index. keep in mind that those are your categories and your subcategories. So when you're looking for a code and you're reading from the documentation, it's important to keep those lines in mind as you look up your codes so that you'll pick the correct, so you can go to the correct tabular code in the back. Then use of and with. When the term and is used in a narrative statement, it represents and or. The word with should be interpreted to mean associated with or due to when it appears in a code title. That's important, again, in the alphabetic index because there are a lot of subcategories that are termed due to. See and see also. The see instruction following a main term in the alphabetic index indicates that another term should be referenced. It is necessary to go to the main term referenced with the C note to locate the correct code. So again, it's important that you read all of those little tips underneath either your alpha or your tabular index because they're going to be very, very beneficial to you in making sure that you pick the correct final code. A see also instruction following a main term in the alphabetic index instructs that there is another main term that may also be referenced that may provide additional alphabetic index entries that may be useful. It is not necessary to follow the see also note when the original main term provides the necessary code. So when you're sure, you don't always have to kind of go off in another direction to see also. This is new, types of excludes notes for ICD-10. Excludes 1 and excludes 2. A type 1 excludes note is a pure excludes note. It means not coded here, ever. It's it's like a never code. An excludes 1 note indicates that the code excluded should never be used at the same time as the code above with the excludes 1 note. An example, when two conditions cannot occur together, such as a congenital form versus an acquired form of the same condition. Excludes 2, a type 2 excludes note represents not included here. An excludes 2 note indicates that the condition excluded is not part of the condition represented by the code that you're looking up in the tabular, but a patient may have both conditions at the same time. When an excludes 2 note appears under a code, it is acceptable to use both the code and the excludes code together when it's appropriate. Etiology and manifestation convention. Certain conditions have both an underlying etiology and multiple body system manifestations due to the underlying etiology. So, of course, to me, the first thing that comes to mind is diabetes. We all know that there's, your standard DM, and everybody wants this code 250.00. And we all know that there's renal manifestations, there's neurological manifestations, and so we know that that is a code that has multiple body system manifestations for it. For such conditions, the ICD-10-CM has a coding convention that requires the underlying condition be sequenced first, followed by the manifestation. Wherever such a combination exists, there is a use additional code note at the etiology code and a code first note at the manifestation code. Now remember the brackets again. You're gonna know if it's what the alphabetic index is gonna give you an example within the brackets when you go to look up the code. So that's gonna be your first clue as your guide. They'll help you sequence them properly, and you're going to see that in the alpha index. Then when you go to the tabular index, they're also going to again guide you as to what code goes first and what code goes second. Code first and use additional code notes are also used in sequencing rules in the classification for certain diseases that are not part of an etiology and manifestation combination. Then now we have combination codes, and we have a few, but now they're much more combined in ICD-10. A combination code is a single code used to classify two diagnoses or a diagnosis with an associated secondary process or, of course, a manifestation. A diagnosis with an associated complication. So again, we can kind of use that example of diabetes with neurological complications as a combination code now. Combination codes are identified by referring the subterm entries in the alphabetic index and by reading the inclusion and exclusion notes in the tabular list. Again, more little guides for you to pick the right code. Sequela, that's the late effects. A sequela is the residual effect or the condition produced after the acute phase of an illness or injury has terminated, as we talked about a little earlier. Coding of sequela generally requires two codes, sequenced in the following order. The condition or the nature of the sequela is sequenced first. The sequela code, as looked up under S in the alpha index, is sequenced second unless there is an S extension to report the late effect. And again, for those of you who do have your ICD-10-CM books or want to make a little note, you're going to find a lot of those S extensions in the musculoskeletal section. That's a good place to understand how these extensions work, whether it's initial for A or subsequent for D or, again, S for sequela. So that's a good place to get comfortable with using those extensions. Laterality for bilateral sites. Typically, the final character of the code in the ICD-10-CM indicates laterality. And so you'll find that you'll find that repeated. An unspecified side code is also provided should the side not be identified in the medical record. So again, we have left, we have right, we may have bilateral, and then the last code, of course, is unspecified. So this is where, when you're, when you're not getting information that you need to pick the best code for your physician, you need to take his documentation and show him where he needs to give you a little bit more detail regarding that. So if there is if no bilateral code is provided and the combination and the condition is bilateral, assign separate codes for both the left and the right, and then you can use your modifiers. So pretty much in a pretty condensed nutshell here, that's pretty much what we're looking at as far as understanding the conventions and understanding the guidelines just to be able to come up with the correct diagnosis code that your physician wants to use. That even just taking the time to pretty much start on page 1 of the guidelines in the front of the book, and you could even do this in your ICD-9 book if you don't have an ICD-10 book yet, and just kind of be familiar with the information provided. It's amazing how some people have never actually even read any of that stuff in the front of the book, and it will sort of kind of calm some of your fears about what's going to be happening with ICD-10, because the concept is still the same as ICD-9. We're just expanding those codes, and again, some of that fear can be relieved by understanding that a lot of those codes are found in the musculoskeletal section alone, just for left, right, and bilateral extensions. So I hope that was a little bit helpful. If feel free to after the webinar to email some of your questions, and we'll do the best we can to answer your questions and then help you move forward if you feel that's something that you want us to help you with. So again, I really thank you for letting us present this to you, and I'll just turn it back to Arlene then.
Okay. Are there any other questions, Bob, that you got? Or
in fact, we do have a few. So
okay,
all
right.
One. And this question is really, I think, a tough one to answer because I don't think we want to maybe be in the business of I guess, endorsing products. But
okay.
I will give you one name, but I don't think it's going to be a surprise to anybody. But they're asking, have you identified any EHR systems that appear either more or less able to articulate with ICD-10? And so I'll let you guys answer it first, and then I'll just mention one that most frequently is spoken of positively, at least over the last year or so to me.
Yeah. Okay. I guess the best way for me to answer that is SS&G here. We do have a division, product line, where we have someone who works with the EHRs and software to help implement the ICD-10 as well. I am not, I don't know what products those are because that's a whole different product line here, but I can tell you, like I had said before, when I was at this physician's office, and like you said, Bob, I'm not endorsing anything. I just saw it, and it was, IMO that he used with his system, and to me it was beautiful. I'm sure there's tons out there. So I think the biggest thing is you just have to make sure that it's going to be, compatible with your practice management system. So, we do have somebody here at SS&G. If there's more questions on it or they would need some help identifying because of, whatever PM system you're on.
Has a much better knowledge
yeah.
than Arlene and I do, but I'm sure she could help direct you and maybe narrow your search down if you have some in mind, or maybe she could help you.
I think that's a good way to go. I think it might be better to do a follow-up. I mean, there are so many different systems out there, kind of all over the place. I mean, you've got GE, you've got Epic, Care 360, Optum, NextGen. They're all out there. I mean, in my experience, the one that I usually get positive feedback on is Epic, but of course Epic is not cheap. So and especially if the participants, I know a lot of the participants are from public organizations, federally qualified health centers. And budget is tight there, so Epic may not be a viable solution for all. So I think it might be worthwhile maybe for us to do a little background, and maybe we'll try to get back to folks on the call who are interested in that. Regarding it. Again, it would be an endorsement, but we can just kind of give you a general maybe statement of what some folks' experience has been.
Yeah. Okay.
And then we've got a couple of other questions here, so let me just get to those and manipulate my document here. Okay, there were a couple other questions here, and let me just kind of roll through those. Anticipated challenges and electronic claim submissions. Anything that you found, Arlene or Toby?
Well, I think that if your system is ready, and you had to be 50-10, I believe it was in 2000 and
this year. It was April this year.
Yeah, April of this year. If your IT has, tested that. Now, there are some insurance companies, if you sign up with them, and I want to say that Aetna is one of them, that you can, send over some claims with ICD-10 codes on them, and they'll let you know how they
come through.
Yeah, they come through on their system. So you may want to, I forget what, I think they call it like early
implementation.
Yeah, early implementation or something, where they will take those and just kind of help you to make sure that you're good on that. But really, I think, here at SS&G, our IT, we're up and we're ready to go. We really haven't had anybody that has wanted to do that. any of our clients as far as sending the ICD-10 over because, you know, the doctors kind of stepped back when they heard it was going to be delayed. So I guess that's the best answer I can give you. But I would check with your different carriers, and you know, if you want to take the time, send a few claims over to them with ICD-10. It's great. It's a good practice, and then you'll feel more comfortable.
And I think that's something, again, we might want to follow up on, again, maybe for a future session, because I think that's something that's pretty prevalent, and people are definitely doing it and wanting to continue doing it. Another question here. Okay, the impact of ICD-10 on providers, how to coach them and support them through the process.
How to start that?
Basically how to support the
Okay.
providers, you know, as they go through
Well,
the process. They're focused on doing their jobs, and now they have to deal with this again.
Right.
So.
Right. I think that the best thing that the staff can do to kind of help alleviate the doctors, you know, they just want the code, you know, and we want to help them, you know, work as a team as far as if we're not getting the right detail in the code, then we need to go back and discuss that with the physician. But really, what I feel is the best help is to take what you have now, take your super bill, or take your cheat sheets that you use, you know, for your physicians, you know, in whatever specialty that you're coding for. Take those codes, and I don't know if anyone is, you know, like I know the AAPC has a tool that will break out your ICD-9 to ICD-10 codes for you.
Crosswalk.
Right. Yeah, exactly. You can crosswalk through AAPC and a couple other, like we have Supercoder or Encoder, where they'll have a little tool in there under ICD-10. I think that maybe you might even, I don't know if that's in CMS yet, but there's a few free ones. Even if you kind of search around in the internet, you can find some crosswalks. Or, you know what, get an ICD-10 book and then take the codes that are in your listed on your super bill or on your cheat sheets that you use, and transition those by practicing looking them up in the ICD-10 book or using an ICD-10 crosswalk tool, because you're going to find, you know, CHS. That's my, I'm kind of radiology, cardiology. So CHS has like 8 different codes underneath 428.0. So everybody that has CHF on their cheat sheet and it says 428.0, guess what? Now you got to pick from about 8 different codes, and that's where your physician's going to need to help identify which code it is that you're going to pick. So there's sort of the team effort right there. Once you take the codes that you use every day that you're comfortable with and start crosswalking them and transitioning them to ICD-10, it starts to kind of it's not so overwhelming, and it kind of calms your fears a little bit. That looking, you know, the way you look it up in the book is no different than the way you looked it up in ICD-9. So if you even practice that and you follow all those little rules that are underneath in the alpha or the tabular, you're going to have a list of codes. Very few of them actually match, you know, one ICD-9 code to one ICD-10 code. So that, to me, if you want to start to implement something now and sort of like calm the fears of your physician, that's a good place to start. Your coders, you know, give them that project of taking that super bill and converting those codes that you use on a daily basis to ICD-10. And then provide those codes maybe in a little bit of a broken out list to your physician so that he can get used to, or she can get used to looking at those codes and their different structure, and become a little bit more familiar with them. A lot of practices actually started to take the codes like on a daily basis. Maybe you're a family practice physician, you see a lot of hypertension. So maybe every day they would take a new code and they would say, okay, today every time he documents hypertension, we're going to crosswalk our code. And that's a pretty I-10, I think, and is for actually hypertension. So you can practice maybe on a weekly or daily basis, like, hey, you know, it's the diagnosis of the day, and start to kind of whittle down on your super bill. To me, that's going to open up a lot of conversation between the coder and the physician, and I think from there they can get a little bit more comfortable. As far as cash flow and you know, like how all that transition is going to happen, the more comfortable you are looking in the book and the more comfortable you are with the codes that you use every day, probably your top 25 to 50 expanded, those fears kind of start to be alleviated. If you're private practice and you work for a particular physician or you're coding for them, you already have that list available, so your productivity won't seem to decrease as much as it might if you didn't start to even implement any of these codes until a month before you were going to use them. I don't know if that helps.
That sounds very helpful. I mean, I think that we probably got a wide variety of people on the line who are listening to this. You know, some of them may have in-house coders. Some of them may be using an outside service. Some of them may put more of the responsibility on the provider or less. In terms of working with the providers, you know, to what degree, you know, do you like to involve them in the I guess in the training and operational phase with the billing and the coding folks? I mean, you know, obviously they've got to spend most of their time on doing the work, and you know, they have such limited clinical time anyway with their patients as it is. But you know, how do you work that as efficiently as possible?
Now, are you talking
like clinical documentation, or them looking at code up? Prior to ICD-10 or after?
No, I'm talking about with, I guess in general first, but then specific to ICD-10. You know, what do they need to know, you know, so that they are prepared?
Well, I think the best thing would be nice for them to do would be to you know, have some records, maybe actual notes set aside, and you know, what we could do is, you know, we could take those notes. You know, we could contract with the providers, and we could take some of their actual notes, and we could code them out to ICD-10, you know, and then sit down and educate them, either with a conference call or, you know, depending on where they're located, you know, we could do a conference call, and we could go over those notes with them so they can actually see, you know, what they need to do, or are they missing an ICD-10 code that's in their documentation that might give them more reimbursement, because once again, like I said, we really don't know how these payers are going to pay on the reimbursement. You know, our thoughts are, if you don't have an additional code and it specifies that in ICD-10, are you not going to get paid at all? We don't know. So looking at actual notes that they do and having someone like code them to ICD-10 would be a really good educational tool for them. And then, you know, every so often, depending on how accurate they are, you know, you could set up something where you do it every 3 months, pull 3 more notes or 4 more notes, depending. You might want to pull 10 notes if they just can't understand it, you know, but usually that's what we like to do, is have some actual notes that they do, educate them on ICD-10, what are you missing, you know, and we did that with an oncology practice, and, you know, and also, like Toby said, they were running a report of all the patients that had breast cancer. And so everybody who had breast cancer for that day, you know, they put a note on there, and they had to choose the right ICD-10 code, and then also go back in and look to make sure that their documentation was appropriate. You know,
so it's more along the lines of, So is it more along the lines of trying to make sure that the docs are kind of up to date on the most frequently used codes and just the logic and so on, in addition to?
Well, yeah, and you know, actually, you know, I'm going to say that the physicians, as far as clinical documentation, are pretty good. You know, some of them may just, you know, some of them may be, you know, a little lax, and they don't want to give you a left or right, or you know.
Right.
So those, to me, I feel like even when we went through these records of these oncologists, we did their E&Ms, we did their office visit notes, and then we did some of their procedure notes, so that they kind of had an idea of if they were missing some sort of detail, what detail, you know, was it that they were missing. And then, you know, and then it's easier for the physicians to do their documentation the way they're comfortable with, and then just be able to. Then when you try to make a diagnosis for the ICD-10, you'll know right away where their documentation, if it is lacking, you'll know what to ask them to provide. And so basically, it's more like a, you know, this is the clinical information that I need to be able to supply you with the code, and then just the codes that they use on a daily basis per their specialty. You know, it may be one or two different areas in the whole ICD-9 book. You know, obviously, if you're, you know, orthopedic, you need to, you know, maybe be a little, you know, proactive about understanding what all is going to be needed in your documentation. Is this an initial visit? Is this a subsequent visit? You know, is this the sequela? You know, a lot of that type of clinical documentation that the physicians are kind of used to, they understand that.
Okay, one more.
You know, so
one more here, guys. Just are there any additional tricks or suggestions as physicians move to, let's see, as physicians and practices and health centers move to electronic health records across the board? You know, less and less is the doctor's notes, but rather those notes, or whatever documentation is coming through some kind of electronic health record that they're doing on a laptop. Very often, you know, in the patient, in the exam room with the patient. Are there any tricks to, you know, relative to ICD-10 to making sure that the information on that record is useful and helpful and in compliance with ICD-10?
And I think that's getting back to what I was showing, Bob. You know, where the doctor had an ICD-9 code, and he had the drop down in his EMR that gave him all the options, and then right away he went back and he could dictate. Yeah, and he could dictate. It jogged his memory. Oh, it was the right knee. It wasn't, you know, knee pain. It was the right knee, and he went back and he put the right in, and it was an easy fix for him. So I think once you know your options from ICD-9 to ICD-10, just getting that documentation in there, because, you know, we know that down the road they're going to be doing audits, you know, they'll be doing audits on it. So, yeah.
Okay, great. I think that's about the questions, and I think we've just about come to the end of our time. I want to thank you, Earlene and Toby, for all the good information, and we'll try to follow up regarding a couple of questions regarding the AHRs, so on, without getting into the business of endorsing a course, but maybe indicate a couple that are out there that seem to have functioned. If people have additional questions, feel free to submit them. If people want to complete the evaluation on GoToWebinar, that'd be great. If you have any questions, I think you have the contact information for Earlene and Toby on the slide. Also, you can submit questions to Susan Campion, who's our Training and Technical Assistance Director at susan.campion, C-A-M-E-I-O-N, at mgt.com. And the number here, of course, is 703-812-8822. If anybody should have any questions, they can ask for Susan or ask for me. And again, I think this was great, guys, and we'll try to do more of this. And again, if people have follow-up questions, please don't hesitate to put them in writing, And please let us know, what you liked or didn't like. Really, this is kind of for the benefit of the users out there, the providers and administrators, in FQHCs and private practices and public hospitals and clinics, all over the country. So we want to make these as useful as possible. Anyway, take care. Thanks a lot, guys.
Thank you.
Thank you.
Okay, bye-bye.
Bye-bye.